the last sketch, we provided a brief overview of all the components of the hypothalamic pituitary gonadal axis and how they work together to regulate ovarian function and uterine function. In this sketch, we'll be covering the ins and outs, not too many outs actually, of amenorrhea. As we'll soon see, dysfunction of any one of the components along the hypothalamic pituitary gonadal axis can interrupt the menstrual cycle's normal course. Amenorrhea can be divided into two categories based on whether your patient has ever had a period: primary and secondary amenorrhea. Primary amenorrhea is defined as never having had a menstrual period by age 15, or age 13 if there's complete absence of secondary sex characteristics, such as breast development and pubic hair growth. At Sketchy, our recurring symbol for amenorrhea is a white spotless dress. And since primary amenorrhea can be diagnosed at age 15, we've set the scene at a dysfunctional quinceañera. And as you'll soon see, pretty much, I'd say everything seems to be going wrong. The hypothalamus never shows up. The pituitary broke about 30 minutes into the party. And the ovaries, don't even get me started on those ovaries. Secondary amenorrhea is defined as cessation of the menses after a patient has actually had menses. This will be the focus of the second half of the sketch. First, primary. We'll be dividing the etiologies of primary amenorrhea based on which organ is affected. At the top of the scene, we'll illustrate dysfunction of the hypothalamus or pituitary. Then, in the middle of the room, what happens when the ovaries stop working. Then at the bottom of the scene, dysfunction of the uterus and outflow tract. Let's start at the top, with hypothalamic disorders causing primary amenorrhea. Primary amenorrhea is typically caused by congenital anomalies. And our first disorder is no exception: congenital GnRH deficiency. Gonadotropin-releasing hormone, or GnRH, is normally released in a pulsatile manner by the hypothalamus and is responsible for stimulating the anterior pituitary to release FSH and LH. At Sketchy, GnRH is symbolized by a gardener's hardware bag. See how it's being torn by that baby? That's the party planner's son, and he's being a bad baby. Our embodiment of congenital GnRH deficiency. No GnRH means the anterior pituitary is not stimulated to produce LH or FSH, which means that the ovaries aren't stimulated to produce estrogen. No estrogen, no menses. Thus, we see a knocked-over bottle of FSH flower-stimulating fertilizer, a broken LH light, and a wilted female symbol flower, representing decreased estrogen. Interestingly, congenital GnRH deficiency can occur along with anosmia, or absence of sense of smell. This is called Kallman syndrome, and is symbolized by this angry quinceañera attendee calling the party planner, blocking her nose with that flip phone. You see, GnRH neurons actually originate in the olfactory epithelium, and during normal fetal development, these neuronal cells migrate into the area of the hypothalamus. In the case of Kallman syndrome, a genetic mutation disrupts the normal GnRH cell migration, and on top of that, the olfactory bulb remains underdeveloped. Girls with GnRH deficiency have no estrogen, and as a result, do not develop secondary sex characteristics, such as enlarged breasts or pubic hair, in addition to amenorrhea at puberty. Our recurring Sketchy symbol for the absence of secondary sex characteristics is our totally grunge X-eyes smiley face shirt. An X over each underdeveloped breast. These patients are given estrogen replacement as treatment, which allows them to go through pubertal changes and have normal menstrual cycles. Although we are focusing on girls, GnRH deficiency occurs in boys as well, similarly shutting off the gonadal system and causing delayed or absent puberty. Alright, let's move further down the hypothalamus pituitary gonadal axis, to the ovary. Looks like the party planner's daughter is also a party pooper. She's got her hands full with all these wilting ovarian flower beds. Our symbol for the ovary is a flower pot growing follicle flowers. Some of them usually look like female symbols too, to emphasize estrogen production by follicular granulosa cells. Any disorder that directly affects the ovaries will cause them to produce less estrogen, as depicted by those female symbol flowers scattered on the floor. In this setting, expect LH and FSH levels to be high due to decreased negative feedback on the hypothalamus and pituitary. So we've got the LH light turned on full blast, and we've overloaded that flower bed with FSH flower-stimulating fertilizer. But nothing's working. Remember that primary amenorrhea is usually caused by a congenital syndrome, which is the case here at the ovary too. In fact, the most common cause of primary amenorrhea is gonadal dysgenesis due to Turner syndrome. We symbolize Turner syndrome with a turning pinwheel, kind of like the little propeller thingy at the end of the spray bottle. And it's X-shaped to remind you that patients with Turner syndrome have a 45XO genotype. That means just one X chromosome. In Turner syndrome, the ovaries are usually atrophic due to degeneration of the follicles with replacement by fibrotic connective tissue, also known as street gonads. As a result, these atrophic ovaries can't produce any estrogen. leading to the same symptoms of primary amenorrhea and lack of secondary sex characteristics at puberty. Girls with Turner syndrome are given estrogen in order to stimulate secondary sex characteristic development, as well as normal menstrual cycles. Other symptoms of Turner syndrome include short stature, webbed neck, and widely spaced nipples. Check out our upcoming sketch on chromosomal disorders for a more detailed discussion. For our next cause of primary amenorrhea, let's head to the bottom of the scene, where we'll illustrate a few anatomic disorders of the uterus or vagina that physically prevent menstrual blood from coming out. The hormonal cycle is fully normal in these cases since the hypothalamic pituitary gonadal axis is intact. We just physically can't see any evidence of menstruation, since it either doesn't occur or can't exit the body. Our next cause of primary amenorrhea is an anatomic abnormality of the uterus, congenital Müllerian agenesis. Just can't get that mule to budge. First, a little embryology review. The early embryo has two pairs of genital ducts, the Wolffian or mesonephric ducts, and Müllerian or paramesonephric ducts. In a normal female fetus, the Müllerian ducts develop into the fallopian tubes, uterus, and upper third of the vagina, all incorporated into the mule's head, fallopian ears, uterine head, and even the tongue, representing the proximal vagina. In Müllerian agenesis, also called Meyer-Rokitansky-Kuster-Hauser, also called MRKH syndrome, the Müllerian ducts don't develop, so the fallopian tubes, uterus, and upper vagina are absent. Of course, without a uterus, there's no menstruation. However, the hypothalamic pituitary gonadal axis is completely functional, meaning the hormonal cycles are normal. Girls develop normal secondary sex characteristics, but just don't menstruate because there's literally no uterus. Lastly, primary amenorrhea can occur in another anatomic disorder, imperforate hymen. The hymen is a membrane composed of fibrous connective tissue that attaches to the vaginal wall. Normally, the central portion degenerates during development. But if it doesn't, you're left with an imperforate hymen. The typical story for imperforate hymen will be an adolescent girl with fully developed secondary sex characteristics. The hormonal cycle is fully functional, after all. But with primary amenorrhea that presents with cyclic abdominal or pelvic pain due to pooling of menstrual blood in the uterus and vagina, with no way for it to leave the body. This is symbolized here by this bag of blood-red utensils that just won't drag. Fortunately, imperforate hymen can be easily remedied with a surgical procedure. That's it for primary amenorrhea.